Good morning, everyone. My name is Eve Lossman. I'm an emergency physician at University of Michigan, and I work with the CDC-funded Injury Prevention Center here at the University of Michigan. On behalf of our team, I want to welcome you to the third in our series of webinars focused on safe prescribing practices and reducing overdose deaths related to the opioid epidemic. This is our third in a series of discussions. The first was in February, focused on safe prescribing. The second was in July, focused on equity in pain management, as well as the treatment of patients with opiate use disorder. And today we're going to focus on harm reduction. We have approximately 90 minutes for this discussion, and we have built in time for Q&A. So please do ask questions. So let's get started. Jill, next slide. We have a fantastic group of speakers today. Our panelists do not have any disclosures to share. The first speaker is Steve Alsum. He's the executive director of the Grand Rapids RED Project, a harm reduction organization based out of West Michigan and providing direct services since 1998. Steve has been involved in harm reduction work in the state of Michigan since 2007. Our second panelist is Valerie Kelley-Bonner. She's the founder of Strategies to Overcome Obstacles and Avoid Recidivism. This is a nonprofit prevention services provider in the Detroit-Wayne Mental Health Authority. She's also the CEO and lead consultant of Strategic Transitions Consulting. Last but not least, we have Ashley Shukait. She's a liberatory harm reductionist and public health consultant working in southeastern Michigan. She has coordinated a harm reduction and overdose prevention mutual aid group for over a decade. She has worked in healthcare, and she has managed a legacy syringe access program. Our three speakers bring a wealth of knowledge in this space, and we are really thrilled to learn from them. And then last but not least, I'm Eve Lossman. I am an emergency physician here at Michigan Medicine, and I will be your moderator. Jill, next slide. As we have discussed in previous presentations, and as we will discuss again today, a holistic approach to the opioid epidemic is critical. And as providers, we need to be patient-centered. We need to educate ourselves to better serve our patients. And with education, with advocacy, and with focus on the problems at hand, we can certainly bend the curve and make a difference. This is visible currently in some recent statistics showing that opioid-related overdose deaths are actually coming down in our communities. We are making a difference, and we need to continue to work with the many people in our communities who are advocating for patients and doing critical risk reduction as well as harm reduction work. Next slide, please. So as I have alluded to, there are a lot of topics in this space. There's a lot of work to do. And today we are going to focus on one incredibly important aspect, namely harm reduction. Next slide, please. So this is today's agenda. We have decided to be informal in our small group, so I'm going to use first names. Steve is going to summarize some of the impacts of federal and state public policy, the drug war, for lack of better terminology, on the ability of organizations to provide substance use disorder treatments, as well as harm reduction services. Valerie is going to describe harm reduction as related to illicit drug use. She's going to distinguish between harm reduction and risk reduction interventions. And then Ashley will close out our discussion by describing risk reduction interventions above and beyond naloxone and how to implement them in our day-to-day practices. And last but not least, we'll have Q&A. So without further ado, next slide. I would like to introduce you to Steve Alsum and turn the baton to him.
Thanks, Steve. So hello, everybody. My name is Steve Alsum. I'm the Executive Director of the Grand Rapids Red Project. We're an organization based out of West Michigan, providing harm reduction services since 1998. Today, I'm going to talk about some of the interventions that we can provide within harm reduction that are evidence-based with regard to reducing death in the context of the overdose epidemic, and then talk about some of the policy barriers that we experience here in the United States towards providing those interventions. So next slide. So the basic premise that I'm going to try and make through my piece of the presentation today is that the social conditions in which substance use exists in the United States often do more to impact the risk an individual is exposed to than their individual behaviors do. Within harm reduction and risk reduction, HIV prevention, we do a lot of focusing on behavior change. And behavior change can be really important, but it's not all of the picture. There are policies in the United States that make it really hard for people to protect their health and stay alive. And no matter how much people can and do change their behaviors, they're still going to be subject to those policies, those harmful policies that exist here in the United States. So while we can and do work around behavior change, we also need to change policy if we want to make progress in this fight against death, really. We need everybody's help to do that, and it's vitally important. Next slide. So we really can't discuss drug use without discussing the context in which drug use exists, and that context is the war on drugs. So I'm going to set the stage with that with a few slides. Next slide. So the current war on drugs was instantiated by President Richard Nixon in 1971 when he declared drug abuse as public enemy number one. What they try to tell us with the drug war is that they are trying to stop people from using drugs, trying to keep drugs from coming into the country, but none of that has happened. They've spent trillions of dollars on that. The real goal of the war on drugs is and always has been disruption of Black and Brown communities in the United States. So this is a quote from John Ehrlichman, who was one of President Nixon's aides at the time the current war on drugs started. He said that we knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. Did we know we were lying about the drugs? Of course we did. And this is exactly what's happened from the drug war. Next slide. So actual outcomes of the drug war through 2019, from about 1970, there's been about $2.5 trillion. The rate of substance use disorder in the United States has remained the same, about 1.3%. So there's been no change in the rate of substance use disorder in the United States during that time. Yet we've seen huge increases in incarceration over drug crimes, over 1,000% increases. And those increases haven't been caused by any increases in substance use. They've been caused by changes in policy. Next slide. So the current state of the U.S. correctional system, over 50% of the people who are incarcerated in the United States are incarcerated based on charges related to drug offenses. The prison and jail population looks very different than the United States population. Is primarily, again, Black and brown folks who are being policed, prosecuted, and locked up for drug crimes in the United States. And this was always the intention. Next slide. The drug war has not achieved its aims. You would think if the goal was to decrease drug use, you would think that there would be some changes in the availability of substances in the United States. This is data taken from the DEA, so taken from the federal government. What it shows is basically over this time period, the average purity of heroin increasing in almost every major city in the United States, as well as the price per pure gram of heroin decreasing over this time period. So if anything, for these trillions of dollars spent on the drug war, drugs have become more available in our communities, they become purer, and they become cheaper. Next slide. So another dynamic at play in the context of substance use and its criminality is the iron law of prohibition. So the iron law of prohibition basically states that the more prohibited a substance becomes and the more enforced that prohibition is, substances will tend towards their most concentrated form. We're seeing this right now with the transition of the opioid supply in our communities moving from heroin to fentanyl. We also saw this during alcohol prohibition. During alcohol prohibition, a lot of folks might have preferred to drink beer or wine, low alcohol content beverages, but what was available was very high alcohol content beverages, and we saw public health impacts from that. And as a result, alcohol prohibition was repealed. So now we're seeing that same thing happen with the transition from heroin to fentanyl, a more concentrated form of an opioid. And we're also seeing the similar public health impacts from that transition. But we have yet to repeal drug prohibition like we did alcohol prohibition. Next slide. So I'm going to talk about some of the evidence-based interventions that we have available to us here in the United States to reduce fatality from overdose, as well as some that are not available to us here in the United States. And I'm going to talk about some of the policy barriers to enacting them. So the first one I'm going to talk about is syringe access. And all the folks presenting today work with syringe access programs. So next slide. So I like to contextualize harm reduction within the context of human rights and people having a right to have access to the knowledge, tools, information, and support that they need to stay healthy. Within the context of injection drug use, one of those tools people need to stay healthy are sterile syringes. Unfortunately, a lot of places in the United States and right here in Michigan, sterile syringes are criminalized. So here in Michigan, we don't criminalize sterile syringes on a statewide level, but many of our local communities have paraphernalia ordinances that result in people getting drug paraphernalia charges for possessing this public health tool. So this is a quote from Human Rights Watch from a study they did in Russia looking at access to syringes in Russia. The conclusion they came to was that impeding the injection drug using population from obtaining or using sterile syringes amounts to prescribing death as a punishment for illicit drug use. What they found was that there were impediments to people accessing this tool in Russia. There are similar impediments right here in the state of Michigan right now. Next slide. So in late 2014, early 2015, we saw a worst case scenario happen in a rural county in southern Indiana of what happens when we criminalize access to the public health tools that people need to stay healthy and stay alive. So at the time, syringes were illegal in Indiana. And as a result, in Scott County, Indiana, a small rural county in southeastern Indiana, we saw a huge HIV outbreak. This was a county that typically has less than 5 new HIV cases each year. In a 6-month period over the winter 2014, 2015, there were over 150 new cases of HIV identified in this small rural county, with over 95% of them being related to injection drug use. So what happens when we criminalize the tools that people need to stay healthy and stay alive, specifically with syringes, is people don't have access to them in the quantity they need to use one for each and every injection, which leads to people sharing syringes, which leads to the transmission of HIV and hepatitis C. And this is a direct result of us criminalizing this public health tool. Next slide. So although we criminalize this public health tool, all the data on syringe access programs, and this is not a new intervention. Syringe access programs have been widely studied here in the United States and internationally, and all the data supports them. So the studies on syringe access have found that programs can reduce the spread of HIV by up to 80%, hepatitis C by up to 50%. A major criticism that people worry about with harm reduction interventions is if we give people the tools to use drugs safely, aren't they just going to keep using drugs? What we've actually found is that the opposite is true, that folks who are involved with the syringe access program are actually 5 times more likely to access treatment than folks who aren't. Programs also protect the community. They can decrease accidental needle stick by up to 66%, and they save an incredible amount of taxpayer dollars. They can prevent the cost of lifetime HIV treatment. They can prevent the cost of hepatitis C treatment for the cost of a sterile syringe, which costs our program about 10 cents. So very, very effective programming, but still is criminalized here in the state of Michigan. We do have a bill that's being heard in the House Health Policy Committee tomorrow morning. It's House Bill 5178 that would clear up a lot of the legality around syringe access in Michigan. Next slide. So although some local communities do criminalize the possession of this public health tool, here in Michigan, we have seen a huge expansion of programs in Michigan over the last 5 years. So from about 2000 to about 2020, there were 4 programs operating in the state. Currently, there's over 30 in the state, but they really operate under a patchwork of legality and illegality. So where we're from, Grand Rapids, people can legally access our program in Grand Rapids. Once they step over the border into Walker or Wyoming, they can again then get a drug paraphernalia charge for the public health tools they legally get from our program in Grand Rapids. And that's the case a lot of places here in our state. Next slide. Something you're probably all familiar with is naloxone or Narcan distribution. Next slide. So naloxone was first FDA approved in 1971. Very safe, easy to use, effective medication. It's been distributed by harm reduction programs here in Michigan since the early 2000s. However, it wasn't available through pharmacies without a prescription until 2017. It's really a crazy thing because we've been seeing thousands of people die in Michigan for years now. And we know this medication exists that's basically a pure antidote to opioid overdose. So why do we continue to see thousands of people die every year in Michigan? It's really a question of who has access to naloxone and the social context of substance use. First responders have always had access to naloxone, but who we typically think of as first responders aren't the actual first responders to an overdose situation. There's always somebody who calls 911 there who can and should have access to naloxone. So we found that the most effective programs at keeping people alive from overdose naloxone distribution programs are those programs that focus on reaching other people who use drugs. Next slide. So naloxone, we've heard a lot about it, but it's really the result of harm reduction programs that this medication is as accessible as it is in our communities now. It wasn't doctors in the medical community who initially made this medication available in the early 2000s. It was really harm reductionists and people who use drugs who liberated this life-saving medication from the medical community. Next slide. Access to medications for opioid use disorder is another intervention that we do have available to us here in the United States that's shown to save lives from overdose and where a lot of work can be done. Next slide. So typically when people think about effective treatment, you talk to people about effective treatment out in the community, what people think you're talking about is abstinence-based treatment, sending people to detox or to 12-step groups. But what we found is that abstinence-based treatment is actually the least effective form of treatment for opioid use disorder. And when we look at the effectiveness of different types of treatment compared to their acceptance in the community, the effectiveness of different types of treatment is often inversely proportional to how acceptable they are in the community. So people typically find abstinence-based treatment to be the most acceptable. Next, they find naltrexone to be acceptable. Then buprenorphine, and least acceptable to most people in the community is methadone. But when we look at the actual effectiveness of these different treatment methods and helping people to improve their lives and helping people to stay alive and not overdose, it's exactly opposite. Methadone is the best treatment option, then buprenorphine, then naltrexone, then abstinence-based treatment. Next slide. So methadone and buprenorphine are not only effective at helping people to improve their lives in ways that they want to, they've also been found to be very effective at decreasing people's risk of overdose death. So methadone and buprenorphine can actually decrease risk for overdose death by 66 to 80%. There was a study done in France after they vastly increased access to methadone in 1995, and they actually saw a 79% decrease in overdose nationwide. So despite this evidence, why isn't this widely available in the United States? This is something really where we could do a lot of work pretty quickly. Next slide. So this is a map of medication for opioid use disorder availability in Michigan. The darkest gray areas are areas where there's an MOU facility within 10 miles and in the county. The lightest areas are areas where there is a facility offering MOUD within 10 miles, but not in the county. And then the light gray areas, which you see the most of our state is, are areas of the state where there's no MOUD facility within 10 miles and there's no MOUD facility within the county. So if we want to provide people with effective treatment, we want to help people stay alive, we really got to do better on this one in Michigan. Next slide. Drug checking services are a relatively newer intervention here in the United States. We're just ramping up drug checking services right now in Michigan. So basically, drug checking services are services where people can bring a substance into a facility, have it tested, and find out what is actually in that substance. A huge problem with overdose right now is that the substances people are using in our communities aren't regulated in any way. So people really have no idea what's in them. Without knowing what you're putting in your body, there's not a lot you can do to protect your health. So drug checking services offer people the opportunity to find out what exactly they're going to be putting in their body. Next slide. So again, we like to contextualize harm reduction services within the context of human rights. And I think something that's probably pretty widely believed is that people have a basic human right to know what they're putting in their bodies. You know, think about FDA labels. Most things we ingest here in the United States have an FDA label on them that lists the contents down to the milligrams. Imagine trying to manage diabetes without knowing what your sugar intake is, or trying to manage weight gain or loss without knowing calorie or fat or carbohydrate intake. But this is the case when people are using substances in our community. It's unregulated as a result of criminalization. This information is not available for most people who use drugs. Without information on what you're putting in your body, it's very difficult to reduce risk. However, with information on what you're putting in your body, most, if not all, people will use that information to try and protect their health. So drug checking services in Michigan right now are a continuation of local services that have been provided for years, as well as national best practice. So for years in Michigan, organizations have used reagents as well as test strips, fentanyl test strips, xylazine test strip, benzo test strips, to do some form of drug checking to provide people more information on what they're putting in their bodies. The innovation that we're bringing into this right now in Michigan is using more laboratory technology to give people more information on what they're putting in their body. So on-site Fourier transform infrared machines, as well as sending samples off for GCMS testing. The goal of drug checking, the first goal is really to provide actionable information to end users of substances. People are actually going to be using those substances themselves so that they can use that information to protect their health. The secondary goal is to contribute to our community understanding of what's actually in the drug supply in our communities, and thus our ability to effectively respond to that. However, the elephant in the room with drug checking services is that you can't check drugs without drugs actually being there and on site. And as we all know, possessing drugs is illegal in the United States. Next slide. So significant results we've seen from our drug checking program in Grand Rapids and Muskegon. The presence of fentanyl, it's been ubiquitous in opioids. It's been pretty much non-existent in stimulants. We've never identified a stimulant sample with fentanyl in it. We've seen increasing rates of xylazine in our community. We're up about 60% of opioid samples having xylazine in them. We've identified the presence of nitazines in carfentanil. There's been a new industrial chemical contaminating opioid samples this summer. In just a few months, we've seen samples go from containing none of this industrial chemical to being present in over 50% of opioid samples. We've seen this information lead to people cutting down their use, stopping use, because they don't want to use the substances that they have now found they're putting in their body. We've seen people dispose of substances and also take other risk reduction action, using with friends, doing tester shots. We've also provided information to the community that's led to different practices by medical examiners. And drug checking is kind of like a canary in the coal mine, giving us early warning of what's in the illicit drug supply. Next slide. So this next one is called Pushing the Bar, Safer Consumption Sites or Overdose Prevention Sites. But this is really only pushing the bar here in the United States. These have been available internationally for as long as syringe access has been available here in the United States. Next slide. So currently, there's over 120 safer consumption sites or overdose prevention centers operating worldwide. Overdose prevention centers are places where people can go and use drugs under supervision so that if they do overdose, they can be immediately revived. And these have existed worldwide since 1986, so longer than syringe access has been available here in the United States. Next slide. They're also very effective. Key data point on that last data point is there has never been a fatal overdose reported at any overdose prevention center, saving 100% of the lives of those who experience an overdose there. Next slide. Most places here in the United States, overdose prevention centers are illegal. They'll get prosecuted under the Drug House Act that President Biden actually put in place in the late 90s. However, they can exist with local support, and there are 2 operational in New York right now. During the first 2 months of these programs' operation, there were over 125 overdoses reversed. In their first 3 years, they saved over 1,400 lives in these centers. And again, there has never been a death at On Point or any overdose prevention site in the world. Next slide. Seriously, not one death. Next slide. Not one. So if we really want to keep people alive, maybe we should implement this intervention. Next slide. So a lot of the interventions I've been discussing are downstream interventions. They're addressing the downstream impacts of a toxic drug supply, and we will continue addressing downstream effects of a toxic drug supply and criminalization until we start to address the upstream causes. So elsewhere in the world, they have started to address the upstream causes. And Canada actually beginning providing a safe supply of substances to people who use illicit substances in the middle of COVID. And they did this because they were dealing with the same contaminated opioid and other drug supply we're dealing with here in the United States, as well as trying to have people at less risk for COVID. Next slide. So yes, Canada is actually doing this. Doctors are prescribing opioids to people addicted to opioids, prescribing cocaine to people who are addicted to cocaine, and meth to folks who are addicted to meth. Basically, the premise is folks are already using this contaminated toxic supply and substituting that contaminated toxic supply for a safer known supply. And what folks have found is that it saves lives. Next slide. So this seems like a crazy idea to people when they first hear it, but we actually have a lot of different models for regulation and safe supply that exist right here in the United States, as well as worldwide, that we could use. Next slide. So in review, our communities are undoubtedly in a crisis. We see over 3,000 deaths every year in Michigan, all of them preventable. We know what we need to do to keep people alive. We know what works. Oftentimes, our local, state, and federal policies prevent us from doing much of this. Some of this is still feasible right now under current policies. There's only so often that we can continue doing the same thing and getting the same result before we need to accept responsibility for the outcome. In treatment, they tell you that it's insanity to do the same thing and expect different outcomes. But this is what we're doing with our policies around substance use. So at this point, we need to change policy around substance use if we want to keep people alive. Next slide. So some policy recommendations: we should decriminalize possession and sale of paraphernalia statewide, decriminalize trace amounts of controlled substances contained in used paraphernalia so people feel safe returning that to programs. House Bill 5178 being heard tomorrow will do that. We need to increase access to free and affordable naloxone, specifically to those at most risk for overdose and most likely to use it. Other people who use drugs need to increase access to low barrier MOUD, specifically methadone and buprenorphine. We need to expand access to drug checking services, address the elephant in the room, legality. We need to establish overdose prevention sites and establish safe supply here in the United States. We need to stop looking downstream and address criminalization from which much of this comes now. Next slide. So the next person we have up is Valerie Kelley-Bonner, who's the director of SOAR. SOAR is an organization on the east side of the state that provides a lot of harm reduction services as well. And I'm going to pass it over to Valerie at this point. Thanks.
Thank you, Steve. I salute and respect you for all of the work you have done and all that I have learned for you. You are the greatest. Next slide, please. So I'm going to talk to you about harm reduction as it relates to illicit drug use. Next slide, please. We've all heard about the war on drugs, and we've seen the commercial, this is your brain, and then they crack an egg, this is your brain on drugs. So it's been a lot of that going around throughout the years. But harm reduction has been focusing on building power among the communities that were most harmed, which are BIPOC communities, marginalized communities, communities that have mostly Black and brown people. Whereas harm reduction strategies employed to minimize the harm in these individuals' lives. Next slide, please. We use harm reduction every day. When you get in your car and you put your seatbelt on, that's harm reduction. You don't plan on just running into a wall or crashing into something, but the likelihood that that could happen, you want to make sure you minimize the injury, you minimize the risk, and you keep yourself safe. That's what harm reduction is about. There are other examples: sunscreen, speed limits, birth control, cigarettes. And my classic example when I'm speaking to the faith-based community and BIPOC communities, even your medication, your blood pressure medication. We'll go to a repast and they'll have ham and bacon there, and we know we shouldn't have it. I have high blood pressure. I know I shouldn't eat those things, but because I'm on blood pressure medication, I eat it from time to time because I know that the medication is going to reduce the harm that it would cause to my health. Next slide, please. Harm reduction. This approach accepts that some people will use drugs, but it decreases the adverse effects to their health. Just because they choose to be high doesn't mean they should die. And I'm going to say that again. Just because they choose to get high doesn't mean that they should die. People use drugs for a myriad of reasons, and it's their choice. So we want to reduce the legal impacts associated with drug use and without necessarily requiring abstinence. You know, people say, okay, we'll just quit or just go to treatment and things of that nature. But we need to bridge that sobriety and drug use. And that bridge is harm reduction, providing clean needles, providing other public health tools, providing access, have low barrier, non-judgmental places where people can go to receive these services. And if in fact, and when, if ever, if they decide to stop using drugs, we know that those other places exist. But until that time, they have the right to have access to things that keep them healthy. Next slide, please. There's a difference between harm reduction and risk reduction. So risk reduction seeks to reduce the likelihood of harmful behaviors through education and preventative measures, promoting safe sex, preventing STDs. This could be considered as a risk reduction practice because we're educating people on the process and what harm reduction really is, encouraging you to support House Bill 5178, encourage you to use non-stigmatizing language when you're referring to people who use drugs. So that's all a part of risk reduction. Next slide, please. So naloxone distribution. Teaching individuals to recognize, understand, and respond to overdoses when it comes to naloxone. I have had an experience at a church, a woman who had never been in a hospital before. She was an elderly woman. All of her children were brought into this world through midwives, but she had knee replacement surgery. And as a result of that knee replacement surgery, she was prescribed pain medication. And we're sitting in the repast hall, and I see the signs. She overdosed. We had naloxone, we reversed it, and she's fine. So as part of the education, we must get out of our minds that the only people who need naloxone and need it to be reversed are people who use drugs. That is not true. There's a myriad of situations that we could present today of situations that people have overdosed using painkillers that were prescribed for them. So we want to make sure you understand it's not just people who use drugs. We should keep naloxone and look for the signs in anyone. Safer prescribing practices, implementing guidelines for safer opioid prescribing to reduce the risk of addiction and overdose. Medication-assisted treatment, which Steve talked about, providing access to that. So there are a lot of clinics out there, but the rules and guidelines associated with them create so many barriers. So we could take a look at revising some of those rules and barriers to make it a service that is respectful, that is non-judgmental, and that is low barrier. Next slide, please. Syringe service programs provide a lot. Clean syringes, fentanyl test strips, clean pipes, condoms. We even have hygiene kits and things that we pass out with the harm reduction services. But in addition to that, it creates a non-judgmental, low barrier access to public health tools that can save lives. And while we're out there, we have things for education and training so that we can educate the public on the tools that they should be using. We have pamphlets of information that talks about how to reverse an overdose, how to give rescue breaths, and we communicate that with community members. Ashley instituted something that Sora adopted, and it's called Skill Shares, where we meet with individuals who use drugs and teach them how to use it safely, how to be healthy, along with other things. And of course, data monitoring and research, collecting the overdose data to identify trends and inform targeted interventions. A lot of that goes on of receiving the data and analyze it. But one data point that I always find interesting is they'll say that it's a ton of overdoses in Wayne County and city of Detroit. I'm a Detroiter. And that may be true. But what's interesting about that data point is if you looked at the driver's license of the people that overdose, you may find that they're not from Detroit. They may be from Novi. They may be from Auburn Hills or somewhere else. They just decided to come to Detroit, to get high. And that's where the overdose occurs. So we get a lot of, I wouldn't say credit, we get charged basically with a huge amount of overdoses and their occurrences because that's where it happened. But it puts a black eye on the city of Detroit when that's not just all Detroiters that this is happening to. Next slide, please. Language matters. Use first person language. Don't say crackhead or addict or a person that used drugs, regardless what someone puts in their body, regardless what they do with their body, regardless how they live their life. On the other side of all of that is a human being. You don't have to like, understand, or agree with anything a person that uses drugs says or does, but you owe them respect. Educate yourself and others about substance use. Understand, addiction is an illness and it's a complex issue. It's not a moral failing. A lot of people can tell you stories that's associated with how they even got started using drugs. And this is their coping mechanism, no more than having a drink of wine, having a drink of alcohol, smoking a joint, or whatever it is. So sometimes educating yourself is listening to the stories that are shared. Listening is an art. Most of the time when we listen to respond, not to clearly understand and process what we're hearing. We've all done it, especially in an argument. Somebody makes a point and you want to get in there, you're already formulating your response to that and not really processing and listening to the rest that will be said. It's the same thing when you're hearing a conversation that makes you feel uncomfortable. You're already formulating your response and thinking about how you feel. When you're dealing with someone that uses drugs or anyone, if something is said that makes you feel uncomfortable, stop, drop, and shop within the depths of your soul to find where that emotion is really coming from and stemming from with you, so that when you respond, you can respond from the heart and with empathy. Next slide, please. Support harm reduction. Promote harm reduction programs that provide clean needles, naloxone, and all of the other things that I described. It's interesting that I've had a lot of people who were against harm reduction until it became personal, up to and including on Monday. Someone who really didn't want harm reduction in their city, had a lot of questions, etc., had to reach out to me, for assistance. So, support harm reduction. If you can't support it, don't block it. Don't get in the way of someone getting the public health tools that they deserve to save their life. Challenge your biases. Don't wait until it becomes personal. Look at your beliefs and what you're believing in and see if it's really respectful to someone who chooses to do what they are doing with their lives. Create inclusive environments where people feel included and accepted and not stigmatized and not ostracized and looked down upon. Respect. I don't care if you understand, like, or agree with anyone says or does. You owe them respect. Next slide. Nothing for them without them is a philosophy we adopt at SOAR. Autonomy is important. A lot of rules, laws, legislation, ordinances, and all of those things are made up from people who have never had an experience with what they're trying to police. Nothing for them without them. Have a conversation with someone who uses drugs. Most of the time when policies and things are made, the most important people who need to be in the room aren't in the room. Nothing for them without them. Include them. They are the closest to the solution of your perceived problem that you are trying to solve. Next slide, please. Peer recovery coaches, employing people in recovery, people with lived experience to engage in this work. That is very important. It's called a peer for a reason. That person should be able to identify, understand, and respect what that individual who they are servicing is going through. When it comes to engagement, you can have some understanding if you've been educated and have some knowledge, but you don't have the experience if you have never lived it. And even if you have lived it, everyone's experience is not the same. But it's very important to have someone who at least has been in that situation to be able to understand. So it's important to have someone with lived experience that can really coach someone in harm reduction, public health tools and safety, and if a person chooses recovery in that process as well. Next slide, please. The role of community organizations is huge, but it's also one of the biggest barriers that we have doing this work, especially faith-based ones. So community organizations should be integral in supporting recovery efforts, providing a trusted, Christ-like, resourceful network that may not be accessible otherwise. That's a difficult thing because there are a lot of principles and things associated with faith-based community organizations. And if someone comes in that does not believe, sometimes it's difficult to separate that and even understand it. So the person ends up shutting down because that person they're servicing, their beliefs doesn't coincide with theirs. And that's very unfair, judgmental, and does more harm than good. We have to understand that, and I can't say enough, it doesn't matter if you like, understand, or agree with what someone is saying to you in this work, you owe them respect. And you should be able to listen. And if in fact it affects you to the degree that you feel like you can't deal with it morally or whatever, pass them on to someone else. But don't do more harm than good by being judgmental. It's not helpful. Local outreach. Organizations that have deep roots in the community, really boots on the ground, are the organizations who are really effective. Sometimes that is difficult to do, but that's why it's important to hire people who have lived experience and who understands this work, and to be able to allow them the flexibility to be able to get the work done legally, effectively, and respectfully. Faith-based organizations can offer spiritual guidance, but it should be charitable choice. If that person wants a faith-based approach to harm reduction, provide that. Jesus walked with everybody, and he really didn't wait for them to come into the building to get service. He was with the woman by the well. He was out among the community providing the services and not judging. So if that's what we want to do, then we need to make sure that we are respectful. Next slide, please. There are holistic approaches that you can take, peer-supported approaches, which I talked about, and advocacy and policy change, which House Bill 5178 is about, and hopefully it gets voted and passed on tomorrow. Harnessing the power of community organizations, faith-based organizations, community organizations, advocacy, and peer support gives us a very cohesive public health program to be able to provide harm reduction services. Next slide, please. Again, educating the public, asking questions, sharing success stories, data, skill shares, workshops. All of these things are important in educating the public, our family and friends, about the benefits of harm reduction. Next slide, please. Ending the war on drugs is shifting to a harm reduction approach. Harm reduction is a game changer. And if we could really take the education, the stories, and the success that has been made so far with this program, it'll go a long way in reducing negative consequences of drug use without insisting upon cessation. Next slide, please. I want to introduce to you someone that I love and adore, who has taught me so much about harm reduction and is my right hand when it comes to doing this work in the field, Ashley Shukait.
And so I'm Ashley Shukait. I am one member of a large collective, which Steve and Valerie have been a part of, as well as many other harm reductionists that I have learned from and have learned so much from Valerie, and just honored to be here and work through with everyone. Next slide, please. Okay, go ahead and skip it. So I'm going to just touch base on some of these, since I know the slides will be posted for everybody. But I can't emphasize enough that harm reduction is a social justice built belief for the rights of people who use drugs. And it's rooted in queer, trans, Black, and brown people who use drugs and sex work survival systems. So when we talk about a lot of harm reduction values and on these deeper levels, it's about acknowledging the discriminatory practices and how we shift power to people who have been prone to the structural violence. Next slide, please. They're cute, right? This was years ago, but harm reduction, it's that same thing Valerie and Steve discussed, making sure each other's safe, right? These little bike helmets are, kids know instinctively, how do we not get harmed? And what are ways that we could do this that give us a code of ethics to follow to ensure that we're compassionate, we're safe, and we love each other. Next slide, please. And this also attributes to these healthcare principles, right? Our principles align that we want to use evidence-informed knowledge to protect and promote an individual's right to autonomy, respect, privacy, and dignity. Our practices are going to differ, though, because of prohibition, stigma, oppressive policies that ban fully inclusive care and support. Harm reduction is the missing link that can be applied to all levels of care. It's not an alternative to care. Next slide. Reiterating, we do a lot with minimal resources, and we want to make sure that people get what they need to be safe, whether that's, preventing infectious disease, whether that's sexual reproductive health, whether it's overdose prevention or supportive services. We're there. Whether it's pitching a tip for someone, we're there to make sure that they're safe and healthy. Next slide. how can we humanize people who use drugs? Next slide. So we talked a lot about stigma, and it is these processes. And I used to believe years on early in recovery that it was an individual thing, right? Like I had these internalized stigmas. There was a societal stigma, and we needed to like build power and like create change, which is true. HB 5178, right, has taken years to even get this far. But we have to think upper stream. What are these policies that are enacting stigma, right? Is it someone using drugs behind a locked door because they don't want to go to jail again or have their kids removed? And so we have to think of what are these upper level changes that keep reinforcing stigma and killing us. Next slide. It's created, right? It's a social construct that drug use is a moral failing. And these harmful stereotypes are ingrained in us. But as humans, we're flawed and we've always used drugs. Since the beginning of human times, we can document it. And we all know that animals use drugs too, right? Catnip is amazing for cats if you want some entertainment today. So like ways that we define what's normal, I think we have to challenge that and not live in a world of fear and hate. Next slide. And we have to acknowledge these intersectionalities, right? So we can applaud all the efforts that we're doing with naloxone distribution, getting syringe access out there. But if we're not doing it in an equitable manner that is still at a higher overdoses for Black and Brown communities, then we cannot celebrate this work. We have to really address that oppressed people are dealing with a wealth of inadequate access to healthcare, education, housing, and social supports. And it's on multiple levels, and it takes a really heavy toll on individuals and communities. Next slide. Language matters. People have the right to self-identify, and many individuals have had these negative stereotypes reinforced about themselves. And so we want to acknowledge like people have the right to refer however they want to. But when we're interacting as professionals with our colleagues, that's when we really ask to use that person first language of people who use drugs. Maybe they don't have a substance use disorder, right? Maybe they're working and just on the weekends they're using drugs. We don't know, but identifying that humanity first, I think is really important to start changing stigma. Next slide. Steve, Valerie have done an amazing job. Like, how can we do better? Avoiding judgment, assessing our own biases and our own beliefs and challenging that and just sitting with it, right? And how can we make sure that people are treated the way that they want to be treated, but knowing and acknowledging that they're experts in their own lives? Using active listening, and don't just do something, stand there. And I did not say that backwards. Just sit with it. You don't have to be a savior to everybody. Just acknowledge that you're here to help them can go a long way. Next slide. Trust building within systems. Something years ago, was like, I have a healthcare background, and it was very early on that was like, wow, I really want to help people as I had my own struggles. But realizing within that system that we operate, that you can never fully be trusted and those systems cause harm. And if we can reflect on that, people can't always be honest when they go into healthcare settings. There's reasons, and that needs to be changed, but we can acknowledge it as providers, as individuals with a different, to help people. Next slide. We need a safe supply now. I cannot emphasize that enough at this point. I have never seen the supply as bad as it is. It's unregulated, it's inconsistent, it's uncertain, and it varies across regions, times, and communities. And it often, has this boogeyman effect to where, this individual's, doing harm, when really powders look alike, right? Like if we laid out 20 drugs on the table, like half the time we can't identify what's in it or like what the percentages are. And cross-contamination happens. Like think if you were mixing different spices on the same table and, you were working in this hyper surveilled environment, stuff's going to happen, right? And it's going to get messy. And people have always used various substances. Like this is not a new phenomena. Polydrug use has always been a thing. Ask any drug user, like, we may not want to admit it, but like everybody's used multiple drugs, right? And it happens, but when you don't know what you're getting because we don't have a safe supply, then it makes it harder to regulate. And I think with stigma, a lot of the times the messaging is such a fear-based centered messaging and people are numb to it. And so how can we do better? And so can we get harm reductionists to do artwork and notify others? I'm totally plugging Andy G. His artwork that goes into the community and provides information is huge. There's never a point that public health messaging, healthcare messaging will ever be better than community-centered graphics, harm reduction zines, and other messaging. And so I love tardigrades. If you didn't know that, it's my favorite animal. And yes, they're a micro animal. So visit his Patreon, right? Like support community artwork so we can get those messages to people. And, when we talk to individuals, what is the message that we're describing a substance? If you just said, oh no, there's fentanyl and cocaine, everybody's like, well, okay, shit. Like what cocaine? Like, what does it look like? What bag? What, like we have no descriptions. It's just like this big fear mongering and people are like, well, okay, whatever. Right. Like look at COVID. We've done a horrible job with public health messaging and it was so fear-based that it wasn't realistic for many people and they fell off the wayside. And does it stigmatize people who use those substances? And I think that's something that if we start focusing on people with lived and living experience in the community, that's going to make a bigger difference. Next slide. And so I'm going to really go through this quick, and just highlight some main points for practical tips. And so like lead with openness, right? If you have somebody in your space that has living experience, and hire them, pay them an equitable rate, and make sure that your clinic or your practice incorporates that. Always making sure that you tell people, like, I want you to feel supported and safe, however that feels right to you. Don't be a savior. Safer, not savior. So be upfront if there's limits that you can't discuss, right? Like if you're a mandated reporter, talk to your patients. Talk to your clients. Is there a safe word that you're like, hey, you're talking, you're saying something I'm going to have to report, like find a safe word so that they stop. Oftentimes people are talking, I'm like, shut up, right? Like we've all done that. But finding ways that you can be honest about that conversation and assess your own beliefs, the way you treat people. And that is a huge one, unfortunately, when ER staff, other healthcare staff, like, y'all are busy and you're overwhelmed too, right? And so like we can be really jaded when we see people on their worst day. And if we don't have experience on any other day with those individuals or that population, that is how we form stereotypes and beliefs that can be damaging. Next slide. Is it relevant? Like, do you really need to know if they're using drugs? Like, really ask that. Like, do I need to document this every single time that goes into their chart? Because right now, if you have a SUD diagnosis or, quote, drug-seeking behavior, that's not a thing, but it can do real damage and harm to individuals. And does honesty come with punishment? Maybe not you, but maybe your hospital practice, right? And so like really questioning like your work and is it a trauma-informed environment? And do you ask about risk, the set, and settings? And so Zengberg is a researcher, and he really went through about people's drug use practices and what are those relationships that could be supported and helpful. Next slide. So I'm just going to go over some tips. Please do not ask all these questions at once. You're going to make somebody run out of your clinic or your space if you do. Next slide. So risk refers to the drug use or risk refers to the drug use or the sex work specific issue that you're discussing. So like that chief complaint. What is the issue that the patient's concerned about? If it's drugs, how are they using their drugs? What is the route? What is the frequency? And what about the cuts, right? There's acute and chronic health conditions with some of these cuts and the consistency of their supply, the source, the potency. Like there's so many factors to somebody's drug use that could put them at risk. Next slide. So very drug specific questions, starting off with context. Is it okay to discuss your drug use to make sure I can provide you the best care that works for your health goals? Can you tell me about the substances you use? And make sure people know, like, it's not just alcohol. And being aware that, they're using drugs maybe to stay well. And so maybe it's not a discussion of like, when do you use drugs? Maybe it's just like, hey, how often are you trying to feel well? Or what is your ideal of usage that makes you functional and happy? Next slide. The supply is a hard one. We need safe supply, but there's also ways to ask people to kind of reduce some of those risks and setting it up and just saying like, the drug supply is unpredictable. I see some of these test results and I want to make sure that we're addressing these things for you. Do you have a consistent supplier that you trust? They don't always have a choice, but we've also seen, suppliers provide naloxone. They provide all these educational pieces that they can within their limitations and seeing if they have somebody. Does your supplier or you have access to fentanyl test strips or other technologies? Find out where your harm reduction organizations are so you can refer them for drug checking programs, right? Promote that within your office. And like explaining to individuals, like some of these cuts like levamisole and cocaine cause kidney problems, or xylazine and dope, we're finding causes wounds and anemia. Have you noticed any problems related to your health or supply? That was one thing years ago, was like everybody was getting wounds and nobody cared, right? Or just, oh, it's an abscess. And if we don't have these discussions and knowledge of what's going on in the supply, we can't really treat their health conditions. Next slide. Skin and soft tissue. That's a big thing. I see more people have infections and die of infections than just overdoses. So when we talk about these harms, we need to make sure that we're including that, because even if overdoses go down, the infections are still going up because people are forced to reuse their supplies because they don't have access. And so does your clinic, make sure that you can discuss these things with individuals, know about safer use supplies, have them on hand, be able to pass them out to people. Don't just give a card and fight for that. And, harm reduction agencies, we're always going to back you. We're going to make sure that your administration understands what really is going on and how can we help protect them. Practitioners are not the ones getting snatched by the cops, period. It's the participants that are being harmed. And make sure you have those resources. Next slide. Another big one is like, ask about their injection practice if they're injecting. Ask about how they're doing it, because you may find critical steps that really get missed that are creating a lot of problems, right? Using alcohol after you inject. One, it leaves track marks, but also it doesn't help heal. So is there a way that you can say it nicely and maybe provide gauze instead of them using alcohol? Do they have access to sterile water? People, unfortunately, that are unhoused may not have access, and they may have to use whatever water source is available. And you can only imagine, from puddles and anything else, what that's going to do to the body. And yes, ask if they lick their needles. Generally, that is a thing that we'll occasionally see, I think less and less with younger populations, but ask in a non-judgmental way, because people do it and it gets missed and people get skin infections from it and endocarditis. Next slide. Sorry, I'm cruising through here, but I want to make sure we have time for questions and answers. So mindset. I've already gotten 6 text messages today of people really stressing out and using drugs that are more risky, right? What are people's mindsets when they're using? What is the situation? What are their internal beliefs? Do they have these internal beliefs of hatred while they're using? Because it gets ingrained in you. And that can make it a lot more risky. What about their physical health? Are they sleeping? People are not sleeping and they're not hydrated, so their risk of overdoses are going up. And do they have access to that and other comorbidities? Next slide. So do they feel anxious? Are they sleeping? Make sure that you are connecting people to services. Next slide. Physical environment, who's around? Are they forced to use behind a locked door? What's the other inequities that exist? Next slide. Do they have a safe spot? Make sure that they have different phone numbers. Never use alone, brave, safe spot, and provide those numbers. Can you document it for them if the police are harassing them? Because you could do really good, get somebody into recovery or whatever that looks like for them. And then as soon as they go to jail, you're back at square one. And so how can you help make sure that you're an advocate and an ally for them? Next slide. Keep in mind, many people who have insecure housing have valid safety concerns, and stimulants may help them with alertness for things like robberies, assaults, and sexual violence. Encourage your patients to eat, drink, sleep, offer them beverages, and make sure community connections. And remember, drugs have benefits, otherwise people would not use them. And most people who use drugs do not have an SUD. And if you only focus on treatment, you harm those with an SUD and miss the opportunities to provide person-centered care for all your patients. Next slide. Oh, dear Lord. Okay. I'm such a data nerd, so I do have the QR code for the Zotero account and then the Michigan Drug Users Health Alliance there for our HB 5187. Please contact your representative. And I'll give it back to Eve. Thank you.
Valerie, Ashley, Steve, that was absolutely spectacular. Thank you so much for sharing your expertise in this space and giving us a lot of food for thought. I am going to ask Taylor and Jill if we have any questions from the audience right now. And while they gather that, I'd like to ask all of you to tell us if there was one thing that you would like our audience to walk away from this webinar and implement in their practice today or tomorrow or in the next week, what is that one thing that you would really like us to all do? And Ashley, I see that your video is on, so I'm going to pick on you and ask you to go first.
Someday I'll get with it. Humble yourself. Really just sit with it and think these are your sisters, your kids. This isn't just other people. Just humbling.
Yeah, I think that's a wonderful point. Valerie, did you want to share anything or any thoughts?
Yes, to add on to that, as I said, nothing for them without them. Just because they get high doesn't mean that they deserve to die. You don't have to like, understand, or agree with anything that they say or do, but respect them and listen.
Yeah, I think that's a really, really critical point. I think person-centered language is incredibly important as well, and that's one of the ways that we show respect. And I've been fortunate to be working on a volunteer team with Ashley for many years, and then got to learn a little bit from Steve last year about some harm reduction kind of principles, and then looking at the bigger picture. I think we perpetrate stigma sometimes in ways that we don't even recognize. And so your point, or I should say Ashley's point about being humble and being open to being corrected. I've been corrected more times than I can count, where I said something stupid without even realizing it. And this is coming from somebody who works in this space and cares deeply about doing a good job in this space and taking good care of the patients who come to the ED. Hold on one moment. I see something in the chat. So let me just see. Okay. We had 40 people at one point in the audience. Does anybody have any other questions that they would like to ask of our panelists? This is your chance. And any last comments, Steve, Valerie, Ashley, based on kind of hearing each other talking in this space, anything that kind of stands out to you or that you want to maybe reinforce?
Well, I guess just like being that this whole series is around, safer opioid prescribing toolkit. The most harm right now in the United States is being done from the illicit drug supply, not the prescribed drug supply. So, what safer opioid prescribing means to me is replacing the toxic illicit drug supply with a known drug supply, having prescribers prescribe opioids, a known substance, to people who are using the toxic illicit supply right now. Well, I think that's really the direction that we need to move, and it's not going to move that direction with harm reductionists advocating for it. We need people in the medical community, on board with that. So safer opioid prescribing is replacing the toxic illicit supply with a safer supply.
Yeah, and that's really a paradigm shift in thinking for the medical community. And I'm just one member of the medical community, but that is really a paradigm shift. What I will say is, for anybody who's interested in going back to our first webinar, we did talk about the negative impacts of the initial CDC safe prescribing guidelines, where a lot of providers interpreted those guidelines as either stopping fairly abruptly or tapering very quickly their patients who were receiving long-term opioids for whatever reason. And this unfortunately pushed people into behaviors that were very negative for their health, whether it was doctor shopping, whether it was drug seeking. I myself saw many patients who, came into the ER and they said, I'm desperate. I don't know what to do. I am experiencing withdrawal. I was prescribed X for 10 years, 20 years for an injury, and now all of a sudden I'm not being prescribed and I need help. And the newest iteration of the CDC guidelines caution providers against this kind of blanket cutting patients' prescriptions or tapering too rapidly. But we still have kind of this very narrow view of how to manage pain. And we have very few tools. And then, to put on top of that, childhood adverse events, trauma, and Ashley said it very well. People use drugs for reasons, right? And how to make sure that use is safe, and that people's lives are preserved, and that their health is preserved. Those are the goals of all of the work that you guys are doing, obviously, but that's part of the goal of these seminars, is to really raise consciousness, raise awareness, and get people thinking about how they might perpetrate the negative situation that we're in right now, and how each of us can work towards rectifying the situation and making it better for everybody in our community. We are at time, and I'm not seeing any additional questions. I want to thank our panelists. This was an absolutely wonderful presentation. Thank you again for sharing your expertise. I know that the Injury Prevention Center team is going to put this recording on our website. The slides will be made available to everybody who attended. Thank you, participants, for your attention today. And please reach out if you find that you have a question an hour from now. Our staff will do its utmost to either answer the question directly or forward it to our panelists so that you can get an answer. And with that, I will say goodbye and have a great day. And thank you again for joining us.